is the first page, because on the first page is how you prioritize your actual EKGs. The cover of this is huge. The actual cover gave you an answer on the test. In other words, which EKGs are more important than others? This is in order. So what do you say is the most important one?
VFIB.
VFIB, right? What's after that?
VFIB.
Then what?
PVC.
Yes. Now, here is what I need you to do for your girl. Do you see how you have PVCs? At the end of the sentence, please write torsades. That's the next one, torsades. Now remember, your OMG packet is a sneak peek of everything. So this is torsades. And if you do me a favor and pull up your Oh My God packet, we were on pharmacology if you'll remember. Open up your Oh My God packet to page 7. I want to show you something. If you look at page 7, the bold print, the last bold print is your EKGs. Do you see it? Mm-hmm. You sure? Yes. Okay, page 7, right? The last, help your cousin. We ain't doing this today. Help her. Okay, so if you look at the EKG prioritization order, what does it say?
B-fib, B-tap, TVC, torsades, A-fib, A-flutter, SVT.
That's the order. You got it. Now, on here, you got your VFIB, your VTAC, your PVCs, and what did I just tell you to do? Throw torsades in there. And then you got your A-fib and your A-flutter. Everybody see that?
Yes.
Okay, now this is something else I need you to know. The last line on this page, the last line, what does it say? Complication, stroke. Didn't we just say that earlier? We said the complication of dysrhythmias oftentimes is a stroke, in particular A-fib and A-flutter. Are you still with me? Yes. All right, now let's go to the bottom, because then we got a little extra love at the bottom of the page. If you look at the bottom of the page, remember, this is as easy as also remembering how the order goes for your alphabet. P, Q, R, S, T. That's very important that you know the order of your alphabet, and everybody here does, so don't act crazy. You know P comes before QRS, and you know T comes after QRS. Are you with me? Yes. Now, so if we look at the bottom of the page, the very first thing we can kind of notice on an EKG, and the place where we kind of start with the big old complex, is we start with the P. What I need you to write on this page for your P wave is that this is a contraction of the atria. That's what it is. It's your atria contracting. Now, you got to remember what I said earlier. The atria were the tops of the heart. Remember, y'all? The atria was in the top part, the ventricle at the bottom. Remember? Okay, so this is all about the atria, and you got to think about it. The atria in the heart, the atrias in the heart are smaller than the ventricles. So therefore, the P wave is smaller than the QRS. Look at that. Look at that thing. Look at that complex at the bottom of your paper. See how small the P is? Here's another tip. The P wave is smooth and a half moon. It's smooth and it's like a half moon. Every now and then it's like this, but most of the time it's smooth. You got me? The QRS, that ain't smooth because you got 3 letters. The QRS complex is a big old spike with the R at the top of the spike. Are you with me? When you count them damn R's, you got your heart rate. Simple. When you count those R's, you get your heart rate. Now, in a real EKG, not the one down at the bottom of this page spread out so you can read it, you are going to see this P wave. Here we go. You're going to see that P wave, boom, hugged up against the QRS immediately before it. If there's a pause and it's not immediately before it, if it's a P wave and then a QRS, that was a long ass pause. That's what heart block is. That's heart block all fucking day. A P better be right up against a QRS. If it's not, it's heart block. Heart block is the least likely EKG on NCLEX. Least likely. And I'll show you the most common. But that one, heart blocks, are least likely. The T wave looks like a bigger P. Again, this T wave looks like a bigger P. And it always comes after the big spiky thing. You got it? And the last thing I'm going to say about that T, because it's on your test, is that the T wave is all about potassium. So your T can look real spiky if your potassium is high. And we call that a peaked T wave. Now, I told you, let's see where you following me at. I told you the P wave was a contraction of the atrium. Remember that? Mm-hmm. What do you think this big ass QRS is?
Ventricular.
Yes. Yes. A contraction of the ventricles. Makes sense. Ventricles are huge. They have to have a big contraction. A little bitty contraction ain't gonna fucking work. They need a big contraction. Now, real quick, I'm gonna trace some blood through my heart so you can see what I mean about big versus little. Here we go, y'all. Think of it like this. The blood from your nose and your toes has got to come up to the heart through, if it's going to be my torso, actually my shoulders and my head. Listen, I know you post lunch, you better wake the fuck up. If it's coming from my shoulders, my arms, and my head, this venous blood is going through the superior vena cava. Think about an elevator. And it's going right into the heart. Are you still there? Yes. If it's coming up from my feet, my ankles, my calves, my thighs, my groin, and my abdomen, it's coming up the inferior vena cava. They're the same structure. It's just, are you going up the elevator to get off on 10? Or is you coming down the elevator to get off on 10? Does it make sense? Same fucking elevator. I got to get that through your head. This vena cava is the biggest vein in the entire body. It dumps all of this venous blood with no oxygen in it through the right atria. The right atria only has to contract gently to send the blood through the tricuspid valve to the right ventricle. So let's stop and think about that. Does your P wave have to be that big? No. You ain't went no damn where. You went from upstairs to downstairs. I think you can handle it with a little contraction. On the other hand, the right ventricle, bigger, much bigger than an atria, has to pump blood forcibly enough to get it through your lungs through that pulmonary artery we talked about earlier. And remember how expansive your lungs are. And then remember that the tiniest itty bitty parts of your lungs are called alveoli. And it is the alveoli where the venous blood dumps off CO2 and picks up oxygen and comes right back out those lungs, back into the heart through the left side. We done with the right side. The right side has no oxygen. The right side is venous. The right side is sending blood to the lungs. Because the ventricle has to pump a little bit more blood, pump a little bit harder, the ventricle is bigger, the QRS is bigger. When we come back into the heart from the lungs, this blood is oxygenated. It's called arterial blood. Arterial blood is oxygen all day, venous is not. When that blood comes in from the heart, it's going to go where? Left atria. The left atria doesn't have to pump it very far. It just has to kick it downstairs to the what? Left ventricle. Tricuspid, bicuspid. What's another name for bicuspid? Mitral valve. Our issue, this is important, our issue on this side of the heart is that mitral valve, that bicuspid valve, same thing, can be diseased. If it's diseased, you're gonna get A-fib. It's not on the right side. It's only on the left. A-fib and A-flutter can only originate from the left. So you have this valve that can get a disease. And very often that disease came from strep.
From what?
Strep throat.
Okay.
Back in the day, strep throat.
Wow.
Oh yeah, wow.
Dang, it messed up.
Yes, so you might be wondering if you're intelligent. You might have wondered over these last few years, why does it seem like all the nursing floors have added telemetry? Why is that such a big deal? Why did we suddenly make you guys responsible for EKGs? Why does it seem like everybody and their fucking mother-in-law has A-fib? Oh, I got a simple answer. And that's why when you know where you come from, you'll know where the fuck you're going. So when they try to take your history out of the books, you ought to lose your mind over it, because it's going to provide clarity for your future. So here we go. When did penicillin come out? What year?
1970.
No one does.
Like 30.
The 1930s. Before that, was there a cure for strep throat?
No.
Hell no. When it came out in the 1930s, penicillin, it gave us a way to treat strep. Your grandmothers, well, in your cases, because you're young, your great-grandmothers and my grandmother, they had strep just like our kids get. But when they didn't have a cure, let's not kid each other, it may have come out in the 1930s, but it wasn't in full-blown use to the 1940s. And if you were black, your punk ass ain't see that shit to the 1960s. Because let us never forget our hospitals were inferior. Are you with me? So there is a generation of people that have valvular disease from untreated strep. Mitral valve, rheumatic fever, is very common in these people back in the day. Did they have formal diagnosis? Fuck no, because they couldn't even go to some hospitals. For the record, I couldn't go to the Cleveland Clinic if I wanted to.
I did hear that.
You better. There was only one hospital you could go to, and that was Metro.
Really? Yeah, I did hear
Yeah,
about it.
that's why it was called county. So you were getting undiagnosed anyway. But now, who are these people? There are elderly, there are baby boomers, and they all got A-fib and A-flutter because of strep back in the day. That's critical. That's very important to your understanding of valvular disease, particularly the mitral valve.
Untreated
Strep. Untreated strep.
But is that not the same cause for
Mm-hmm.
the same strep?
Oh yeah, group A strep can cause that too.
So it affects both the
Kidneys and the heart. Okay, so now that's the backdrop. So let's do it because you guys are thebomb.com. You get it now. You understand that when this blood comes from the right or the left atria to the left ventricle, it doesn't have to go far. It's a little bitty P wave. But now let's think about the left ventricle. It's got the biggest job of all. The left ventricle has to pump the blood where? Through the whole body by way of the aorta. Oh my God. Of course the QRS is huge. Now, it gets gooder and gooder. Yeah, I said it. This QRS, every time there is drama with it, is a ventricular problem. This P wave, every time there is drama around it, is an atrial problem. That's how you're going to understand this. So let's do the damn thing. Open up your packets. Let's go to normal sinus rhythm first. Now, you're going to pay attention when we do the normal sinus rhythm. If you look at this, there's this big ass hill falling off the page at the very beginning. Agree? Okay, so we never look at incomplete complexes. We always look for this, the predictable P wave, because we know our alphabet. And we know if we can find the P, we should be able to find the Q, the R, the S, and the T. So we don't go for dumb shit falling off the page. We look for something that looks like an entire normal complex. That would be this first little bumpity bump. Do you see that first bumpity bump? That is a P. Put a P above it. You are on the wrong page. Your page needs to look like this. Flip it. Flip the whole thing. Flip. Nope. See? Keep it the way you had it and flip it. There you go. See that side right there. There you go. Okay, now, so this little hump is a P. This entire spike, entirely, is a QRS, with the R being at the top of the peak. Are you with me? R at the top. And now I want you to put an R on every single top of the spike. Go across the whole thing and put all your R's on top of the spike. So when I come around, I better see R's. So you got a P, a QRS, and remember we said the T is a bigger mountain. And you have a T. Put your T on there, baby. This is your P, QRS with the R on the top, and your T. Now, if you just look at the strip, here are some things I mentioned. I said that the P wave must be hugged right up close to the QRS. Is it?
Yes.
It is. It's super close, isn't it? I said that the T must be a bigger mountain than the P. And it is, isn't it?
Yeah.
Boom. That must happen over and over again. And then if we count our R's, we have the rate, R for rate. So what is this rate?
70.
Yes. Now, here's our issue. On the real test, your EKGs will be basically 6-second strips. That's important as hell. Because this is a simulation of a 6-second strip. That's why if you just counted the R's and multiplied it times 10, you could get the rate for 60 seconds, which is a minute. 60 seconds is a minute. This is a 6-second strip. You multiply 6 times 10, you got 60 seconds. Y'all all right?
Yes.
That's how you gonna do this shit, okay? It's that fucking simple. The number 1 strip on your test is the first strip in this packet. Go to strip number 1. What kind of second strip is this? No. 6-second strip. Agree?
Yes.
How many 6s does it take to make a minute? 10. See, I got all of y'all on that one. Because 6 seconds times 10 gives you 60 seconds, which is minute. And when we're looking at how many heartbeats a minute, that's your pulse. Are you one of those like me whose pulse is always high because I have hyperthyroid and you're 90 beats a minute? Or are you nice and mellow and you're 60 beats a minute? Or are you this guy? How many beats a minute is this? 4. So 4 times 10 is 40. And again, beloved, make sure the R's are on the top of your spikes because all you're doing is counting the R's. For your heart rate, all you're doing is counting the R's. That's it. And multiplying that motherfucker times 10. And this is the number 1 heart rate on your test. Especially if you're an LPN. You got this.
What, number 2?
Number 1, where have you been, baby?
I've been there, but I just...
No, you ain't been there. You ain't been there.
I am. Number 1 is 4.
Number 1. Yeah, you got it. You kind of with me. Okay, now look at this, y'all. Let's have a little fun with it, though, because we got some rules to follow. Okay, let's look at it real close. Is the P wave hugged up?
Yep.
It is. And what was the P wave again? A contraction of the atria. What was the QRS? Contraction of the ventricle. What was the T wave? It was potassium. I thought. That's what I taught y'all. Where the fuck y'all get all that fancy shit from? Okay? Now, so we got this on a test, a real test. We got it. Now, here's our issue. Do you agree that the T wave is bigger than the P wave? It's a bigger mountain, right? And they all kind of flow together. P, Q, R, S, T. They're all together. That's called a complex. When you hear people say, she's got some real fucked up complexes, it means all of that went crazy. Okay? Now, this is a bradycardia. You knew that. I'm not telling you anything you didn't know. Let's diagnose and treat. When we diagnose a Brady, if there are no symptoms, and write it on your strip, if there are no symptoms, we leave it alone unless it's under 40, then you got problems. So no S and S equals, okay, monitor, continue to monitor, right? If there's no symptoms, just continue to monitor. Now, unless it's under 40, because I mean, you got to kind of draw a line somewhere. This is what I was saying to my job the other day. I said, you can't continue to say a bradycardia with no symptoms, leave it alone. Because what, you cool with 2 for a heart rate? Okay, that's a bradycardia. I'm sure you're not cool with that. So where do we draw the line where the symptoms don't make no, never mind, no way? I say under 40, you should care about whatever your patient is doing. My patient had no symptoms, but her heart rate was less than 40s. You can't continue to live like that. And she proved it. She proved it. She coded. But if I were to listen to the higher ups, which was her doctor, tell me, well, she's asymptomatic. Yeah, you are tripping. The symptom is the heart rate less than 40. That's a pretty big symptom in my eyes. What, do you want to go down to 15 and still say that? Where's your drop-off rate? Because mine is under 40. Her potassium was 2.9. She had did her bowel prep, so that's what drug her potassium through the toilet. And she had a history of A-fib and not being on any meds for the procedure. And she coded the next day. And she had positive troponins today. And she was in complete heart block an hour later. You want to keep telling me about how she had no symptoms? You must use your critical thinking. At some point, no symptoms doesn't cut it with me. Okay? All right, so y'all good? Y'all good. 40s, 50s, I'm cool with you and your no symptom having self. I'm cool. We good. Who does that? LeBron James. Who else? Kobe, when he was alive. Who else? Michael Jordan. Who are these people? Athletes. They do it all day long. They come in my department and they're athletic as hell. I can expect their heart rate to be 48. I can expect it. Athletes do this and we don't give a shit. Do we, y'all? So that's why we say asymptomatic does not need to be treated. Continue to monitor. Now, remember, you got a really cool OMG packet. And I want your little ass to go to page 10. Because I have prepared you for what symptoms go with cardiac. In other words, if you look at page 10, there are some specific cardiac symptoms that if your patient says yes to that question, they need to be treated. Here's some cardiac symptoms. Number 1, please write it. It's already in the list, but you're going to need to write it and highlight it. The number 1 cardiac symptom for bradycardia and most cardiac problems is syncope and dizziness. Do you see it? I need you to highlight the hell out of that. Well, keep looking because it's on page 10. It's under cardiac, of course, because we're on cardiac. Dizziness and syncope. That is where you know this patient needs to be treated. So far, so good?
Yes.
Now, there are other things in the list, but one thing that's not in the list, and I want you to put it right by the dizzy and the syncope, is low BP. I want you to write low BP. Because you'll take their vitals and their blood pressure will be low if they're symptomatic. And that's why they're dizzy and they feel like they could faint. Remember the word syncope means they feel like they can faint? Okay. Oh, I did put low BP. You can slap me. I got it in there. I didn't think I had it in there, but I forgot I changed the packets. Okay, y'all all right with that? Okay, now, remember what we said yesterday. We use the shorter word to treat bradycardias because it's the shorter heart rate, and we use the longer word to treat SVTs. So what are we using to treat this patient who's symptomatic?
Atropine.
Yay! Uh-oh, got a harder question. Y'all did good on that one. What if atropine didn't work?
Adenosine.
What?
No,
You trying to kill the fucking patient?
SVT.
Think, not, stop. Think about what the fuck you said.
No.
No, think critically about what the fuck you just said. You told me to take a slow heart rate and give it adenosine, which stops the heart rate and then slows the fuck down. They already slow and you just gave them adenosine. Meet me outside. Every last one of y'all that said adenosine. Come on out here and get your ass up because you're tripping. Now, so atropine did not work. No, that's for fast heartbeats.
Calcium glucose.
This is something I don't necessarily expect my babies to know, but it is on your test. Transcutaneous pacing.
I was never guessing that.
I know, baby, but guessing adenosine make me want to kill you. I get it, y'all. I get it. The answer would have been, Shelly, you on some bullshit? I don't know. Rather than adenosine.
I would have never guessed that.
This is why I'm teaching y'all, because y'all wouldn't have guessed this. I know I wouldn't have guessed this in no damn nursing school. I'm with y'all on that. But this is on your test. Now, you know how you're going to remember? No. This is bradycardia. The fuck? Okay, so listen.
I'm a little sleepy.
I know, I see your ass. Nah, no. Okay, listen how you going to remember it. It's a real good way to remember it. You're going to love this. Isn't it true back in the day, even the people that went to bad schools, hopefully you learned this. Isn't it true that back in the day, if your heart rate was too slow, we give you a pacemaker? Pacing. Pace it. It's too slow. Pace that motherfucker. And remember I said this because it's true for heart block as well. Transcutaneous pacing. Okay? Y'all all right with that? Now, I'm going to say something else about that transcutaneous pacing because it will play a role later. If the heart rate is too slow, you pace it. That's not going to be true for if the heart rate's too fast. So I'm saying if it's too slow, pace it. Okay, y'all good. Y'all good on that. Now, we're going to do another real popular. You ain't even going to have no problem with this. We're going to do another real popular strip. Go to strip number 6. Strip number 6. It looked like you took a pen and did some squiggly doodabs. That's what it looked like. You took a pen and just scribbled on the fucking paper. Don't it look like that? Now you're going to love this one more than anything in the packet. Let's look at it wisely and let's critically think. Is there a P wave? No. Hell no. So that means there's no what? Atrial contraction. That's the bomb. Next question. Is there a QRS complex? No. No. So that means there's no ventricular contraction. Oh, sugar now. Watch it. No P wave. No atria contraction. No QRS. No ventricular contraction. No fucking heartbeat. That's what the fuck that is. It's not rocket science. You don't have a contraction of the top part of your heart. You don't have a contraction of the bottom part of your heart. You have no fucking contraction of anything in the heart. You have no pulse. It's common sense. What'd you say, sugar? Can you guess it? I hope so. No!
It looked like
This is VFIB. Oh my God. Where's the belt?
I said VFIB.
Okay, now watch this. Because look. You see on the front? It says VFIB, DFIB, doesn't it? Yeah. But what does it say next to it?
CPR first.
CPR first. So let's do it. Because you're going to mess this up. Because all y'all little funky ass teachers said, VFIB. No, the fuck it ain't. No, it ain't. Because here's what's happening. Here's how they going to do it on your test. They're going to say you walk into the room and your patient's monitor reveals that they are in VFIB. And you're going to say, oh, well, then my first nursing action is DFIB. No, the fuck it ain't. You know why? Because you didn't walk in the room with defibrillator paddles.
You didn't.
You did not. That's why it's not your first nursing action. No, the fuck it ain't. Your first nursing action is actually chest compressions, because if there's VFIB, there is no heart rate. And if there's no heart rate, there damn sure ain't no response. You did not walk into your patient's room with defibrillator paddles. No one of us did. You got a call for that. You walked in on VFIB, by definition, no pulse, no response. You do the same damn thing you did on anybody else with no pulse and no response. Boom, boom, boom. Start pounding them on their chest. That's how you got to read this test, because it's ready for you, baby. It's got your number. It knows that everybody knows the rhyme VFIB, DFIB. That is not what you do first. You start your chest compressions first. Let's circulate some blood to those organs first. Call for the defibrillator.
First.
What did I just say?
No CPR.
I know, but it was I was doing the personal, and you had to put them in order. But first, they did have like that answer.
I'm gonna try this one more motherfucking again.
All right, see, I know chest compress their ass.
I like her already. Okay, y'all. Now, so here's what I needed y'all to write on here. Where you see the VFIB and DFIB and you see the CPR first, be explicit and put chest compressions. Write your little chest compressions. Oh yeah, we're gonna wake you up today. That's why I do EKGs right after lunch, because y'all be waking up then. Poor little children.
It's actually interesting the way you teach it.
Because I'm crazy, shit. You know your teacher was crazy, and you still paid me, which says a lot. Okay, now, so here we go. Let's go to our little strip of crazy. This is really crazy, right? We agree number 6 is crazy. Now, who does this? Oh, I'll tell you who does it. Patients having a heart attack. Patients drowning. Anybody that's a drowning victim. Anybody in cardiac arrest. Anybody, anytime, anywhere does this strip, okay? So don't go crazy with it, because it's such a common way to die, and you can save them, okay? Now, so you guys, here's what you write on that strip. You write your VFIB. You write heart attack, drowning, cardiac arrest, and then for treatment, you write chest compressions, defibrillate, EpiPen. Now remember, you got to call a code. The problem with the nurses is they think, okay, every time the question says, what's my first nursing action? I'm always going to say, call a code. I have a news flash for you. NCLEX ain't going to ask you about that code calling you so excited about. They going to strictly keep it simple. What is your first nursing action? And you have to say chest compressions. If they give you something and they say, and they won't, but if they were to give you something and say put it in order, call a code chest compressions. Is that helpful? Yes. Call a code chest compressions. But they're not. They're definitely not. And they haven't. And they won't. Okay? All right, so you got it. Now, this is a code blue. So you know already you're going to be doing epi. Right? You already know. You have no pulse, no responsiveness. We're going to pound on the chest, defibrillate, 1 milligram of epi, and on and on and on, over again and over again and over again. Isn't that right? So just remember in the back of your mind, epi will be part of the management.